being here, for being here after lunch. It's really enjoyable and an honor to join this group of speakers. So let me just start with, this is a bit of a frame shift. Everyone has spoken about what they view as good care. I'm going to talk about that, but in the context of why we were having trouble making it happen, which I think is a very urgent question. A couple disclosures. I don't represent the views of the United States government or the state of Alabama. I don't have any pharmaceutical grants, honoraria, contracts, or any history of that. I personally own stock, as part of a mix at Abbott and Merck until 2017. My wife has her own assets that predate my meeting her. I've been typically funded by the National Institute on Drug Abuse and the Veterans Health Administration looking at homelessness, addiction, and policy implementation issues. Let's start with this. The system's level decline in opioid reliance was, in my view, absolutely necessary. We did actual harm through a terrible emphasis on opioids as a central element of pain care. I will not be advocating today for opioids on demand or for never taper. Let me state two theses that I do hope to propose. One is that very good guidance can go wrong in practice, and that forced opioid reductions of a non-patient-centered nature are today all but mandated, absent protection for the patients. Scholarly frameworks can help us explain the problem of translating good ideas about policy into frontline practice, and we need to use them so we can avoid this. The second thesis is that I'm going to proceed from a theory of patient care that's not just about whether we got the opioids right. Health systems tend to misapply guidance documents by neglecting the fundamentals. And the fundamentals are who is the person in front of me. Now, I'm cognizant that there could be a diversity of views in this room on some of the issues I'll raise. So I have a request. I'd like to ask you to sort of walk with me for a bit. I'm going to profile a discrepancy between good care and what is actually happening for patients who receive opioids long-term today. You've heard a lot about what good care would be. We need to talk about the discrepancy. It's not crucial that we agree on exactly the size of that discrepancy. In principle, we don't want such a discrepancy. Let's look at how it occurs. Once we can explain what causes actual care to not resemble good care, then we can make better plans going forward. What might be good care in the area of the opioids? Well, I think pretty good ideas here at the CDC guideline. I'm doing a little violence to other people's summaries, but it says reduce tendency to start opioids, offer better approaches where possible. It doesn't prohibit starting opioids. If considering them, scrutinize carefully the risks and benefits, offer other modalities of care. Exercise caution with dose escalation given the dose-risk correlation that we've just discussed. For patients on opioids already, recommendation 7 says to evaluate the observable harms of the patient and the measurable to the extent possible benefits. It doesn't specify a dose target. It doesn't mandate a dose reduction. So what has happened? Well, clearly prescriptions have fallen. This graph on the left actually shows you a graph that predates the release of the guideline. It's falling before, a little faster afterwards, as Dr. Bonner told us earlier today. It's sped up perhaps. The biggest reduction is in that green category. These are morphine milligram equivalents. We reduced most in the high prescription category, which is heavily dominated by people on chronic opioids. Opioid prescriptions per capita are now 19% lower than they were in 2006, which is the earliest year posted on the CDC's website. But something else happened as well. We began to sort of see, hear, observe, report things that didn't seem right. The story on the left is reported by Fox News, but I had the privilege of interviewing Meredith Lawrence, the wife of Jay Lawrence. I reviewed his medical records and had an expert review it. He was an individual who had a very difficult situation all along. He was potentially quite high risk at the time that opioids were started, to acknowledge what Joe was talking about earlier. He didn't have a wonderful response to that category. But at a certain point, what emerged is this doctor said, look, I'm paraphrasing from the actual interview, your quality of life is not worth my losing my license. So we're going to be reducing you now. And they made one reduction from, I think, 120 to 90. He had a spinal infusion at the same time. And tough. And then the next time it was going to be reduced to 60. And he and his wife made as logical decision as they could come up with, which was for his wife to buy a Ruger and for him to shoot himself through the chest with her holding his hand. After which she was immediately charged with crime. And that was the best they felt they could do in the situation that they were in. I received notice of a new suicide and every few days, so this isn't anything rare, but this is one of the rare ones where we get the records, which is crucial to understand what happened. Story on the right, Washington Post. The briefer, Terrence McCoy, rides along with a trucker 367 miles to get renewal of his prescription. And in this particular story, the nurse practitioner says, it's too much of a risk for me professionally. This will be the last one. And that's, I don't have the outcome of the trucker, but it's kind of, again, sort of a distressing moment. It's not clear that that guy is safe. Official bodies and informal groups began to recognize something was not working out right in 2018. There was a stakeholder letter signed, lead signers Beth Darnell and David Gerling, and many others. I'm just summarizing quickly here. There was a Human Rights Watch report. They did a full year of reporting to try to understand what was going on with these patients, much as they would with any other human rights issue. The FDA issued a warning in April of 2019. They had a reason. They've been asking for questions and information, began to get worried about rapid takers. And indeed, our own CDC guideline authors issued a crucial clarification, restating some of the premises that were obvious for the document if you read it carefully, particularly recommendation 7, and for that, very effective. But we need to ask, how did that all happen? How did we go through a process of responding to a public health crisis, getting to a situation where lots of people are experiencing extraordinary distress? What was that about? Was this all a misunderstanding? Was this maybe a regulatory thing? Maybe too many people passed laws that weren't proper? Was this a lack of help from payers in solving the problem? It probably is going to be elements of all of that. But the most important thing I want to impart to you is that when we ask about implementing a change in the health system, we actually have scholarly frameworks to assess how changes are made. We can even use those frameworks before we make the change so that we make them right. And if we see there's a problem, we can use them backwards to ask what's going on. One of the most common and most cited frameworks for understanding health system change, and this is really my area of work, but I developed this, is the Consolidated Framework for Implementation Research. This is a general framework for a 4-layer cake here. At any time you want to change something in healthcare, you've got to look at what is the intervention you want to make, what's the outer setting, including the policies and the stakeholders who are demanding it, what's the inner setting, including the people who are willing to make that change, and what are the processes put in place to enable that change to be accomplished. I can't cover all that today, but I would like to talk in particular about that second one, outer setting, which is the policies that in this case emphasize dose. There's a kind of separate body of scholarship on policy and how it's made. A book written by Paul Kearney kind of summarizes a number of key principles, and these are not from policy, these are just studies of how policy is made generally. And it's very, very helpful, I think, to get out our opioid crisis and our pain challenge. First of all, for those of us who wish policy was always rational, it is never. Leaders commit to solving problems before they can fully understand them, particularly when they're complex. And most of our leaders have many other problems to solve besides the thing that we spend every day thinking about. Overwhelming complexity often leads to shortcuts. The second key insight, and this will go on to illustrate on the next slide, is that policy is not made by one party or one entity, but by many. There are many competing actors and agencies who can take action on any single problem, whether it's road safety or opioid prescribing or the environment. They all set the policy framework, and that becomes very important in the opioid realm. And the third, and this may be particularly relevant since we're kind of going through a deprescribing process after a pro-prescribing process, policy monopolies can sort of establish a static arrangement where a coalition of maybe a government agency, some corporate interests, and some do-gooders agree that the problem to be solved is this, and the following voices should be heard, and the following other voices shall not be heard. And I think you could argue plausibly, quite plausibly, that we had a policy monopoly in favor of aggressive opioid prescribing as a simplistic response to pain, upheld by a monopoly of interests for a period of time. But policy monopolies fall. Entities come together, sometimes through advocacy coalitions, in response to events, in response to a degree of coordinated activity amongst parties who upset that. And that's really also what's happening. So who makes policy in the opioid prescription realm? Well, I've tried to cordon it off into 4 basic quadrants. There's governmental in the upper left, Congress, HHS, FDA, Department of Justice, DEA, Centers for Medicare and Medicaid Services. Many of these agencies have multiple prescription policies, not just one. Medical boards. We have guidances and metrics like the CDC, the VA Department of Defense guideline, the National Committee for Quality Assurance, National Quality Forum. On the lower right, I've put providers and payers. I'll show you a couple examples. Pharmacy chains, benefits managers, hospital administration, including my own employer, hospitals and chains, malpractice policies. All these entities have something to say about that prescription that has an opioid on it. And then since we doctors are way too busy to read all the endless documents that these entities deliver, we try to get the gestalt by reading the headlines. So if Herman Lopez writes a piece on Vox.com that says doctors gave up opioids like candy, or I see a book cover that says doctors were drug dealers, I think, you know what? I don't want to be that guy. And I might take that home as my central message for today, because I cannot possibly read all the things that these groups write. A few examples, I only chose a couple. This is an act of Congress, the Support Act. It has many provisions to support the treatment of opioid addiction. Interestingly as well, it has within it a provision that every state Medicaid office must set up opioid dose limits. It doesn't say when it should be. It doesn't say exactly how they should do it. It doesn't say if there should be exceptions. It doesn't say there should be forced tapers or not. But every state Medicaid office now has to make a decision about how it's going to deal with it. In my state, there's going to be a max of 250. They're going to reduce it sequentially until it's 90. There's some back and forth about whether or not there will be overrides to that. But that's going to be different in every state because it's part of law and they have to honor federal law. The United States Department of Justice has a voice in this, not just for prosecuting pill mills. Here, there are several communities where this happens. The Department of Justice sends a letter to the doctors identified as outliers in the community. And this was reported in the Atlanta Journal-Constitution. Basically say, we don't know if you've broken the law, but we just noticed you're kind of high relative to other people. We just want you to know, we're watching. Prospect of federal time, very discouraging for most doctors. Just don't want that. Got other things to do well. This is a little snippet of the VA Department of Defense guideline. And what I want you to realize is how, as a doctor, think about who we are. We are trained to try to understand the messages coming at us and deliver whatever performance is wanted, because that's what I did as a pre-med, as a medical student, and as a resident. So here's a little snippet of the VA DOD guideline, the algorithm. And it is not official VA policy, it's a guideline. It asks for the patient already in opioids in the box at the top, do the risks outweigh the benefits? If so, proceed to the taper module, which is on a different page. That sounds a lot to me like the CDC guideline, but then it has these extra things. There's a bunch of things you're supposed to educate the patient on if you've determined that the benefits outweigh the risks, okay? And then there's an add-on question. It's the next hexagon in the box. Are they over 90 milligrams? If so, proceed to the taper module. That is, if the dose is over 90, throw out your risk-benefit assessment, proceed to the taper module. I wish I could tell you that this is clear. It's clearly written here, but it's not consistent with the text of the very same guideline, which specifically does not endorse throwing out the risk-benefit assessment based on the dose. And the issue's been raised many times, and it's an internally contradictory document. But think about the clinician who has to decide which part of this document are they going to follow. It's a high-stakes communication. The career is on. Prescription drug monitoring programs. We're mostly mandated to use them. My employer mandates that I check it every 6 months and document it in the medical record. And I sure as heck try to do that. But for the month of July, when I checked my PDMP, I got a warning. It said, the Department of Public Health makes no guarantees as to the accuracy, completeness, or adequacy of the information in this report. And the PDMP should not be included in the medical record. Why? Well, the truth is that there are a lot of ways you can make mistakes using the PDMP. There are concerns about accuracy. I've seen doctors make mistakes where, in principle, if they knew which button to click on, they could have gotten the right information, but they didn't know how to decode. Who am I going to follow? My state health officer or my employer? That's a high-stakes, conflicting communication, and it's going to produce anxiety. Let's talk about quality metric. National Committee for Quality Assurance established a metric to measure the number of patients in a physician's practice at over 120 more equivalents. Higher is worse. When they proposed this, they received considerable external feedback from people who are experts on the CDC guideline and from their own internal experts that this was a high-risk metric to adopt. They disregarded that feedback. This is the metric. How do you make it better? Well, you can taper slowly and carefully in the way that was suggested by Dr. Merrill, or you can just get rid of the patient. Even if the patient dies, it improves your performance on this metric. Here's an insurer. Basically, it says the CDC has recommended that the doses be brought down. You're going to need to come down to 90 or not. It's a concern. Okay, all those entities are acting. I've only given you a few examples. I got rid of 7 before I came here. What's been missing? What's been missing is safe harbor for clinicians declared by trustworthy authorities to say, we have your back. We won't take you down. It's very unsafe when you're getting conflicting communications from 20 different agencies telling you you could lose everything. Also missing is institutional review, tracking, accountability, related to any harm after opioid stoppage. It's amazing. There are, if you take an article from a few years back, and calculate out, there's about 10 million people on chronic opioids today. A lot of them are having their care changed. Who tracks whether they die or don't die in the insurance panel? Who tracks in the institutions? A colleague of mine visited a set of clinics. They said, we got 75 patients off of opioids. I said, okay, how are they doing now? We don't know. They don't come back here. That's a real event. So if you don't see the patient, it's very hard to know if they're safe. You could check if they're alive or dead, but we don't. In sum, at this point, policymakers have issued conflicting messages that are very high stakes for the clinician. Most high-level actors have transferred their liability to frontline doctors and to patients. They do not typically offer tangible support to meet their mandates, whatever they are in this sphere. On net, this is very scary. What happens in that context? Well, we have a paper out in May, you heard about it this morning, from the Journal of Substance Abuse Treatment. I'm looking at 494 Vermont Medicaid patients who are at high dose, who discontinued over a 4-year period. Median time to discontinuation, 1 day. 21 days, less than 21 days for 86% of the patients. That's pretty fast. 49% had an opioid-related hospitalization or emergency department visit. 60% had a substance use disorder diagnosis in the record. We would want to treat that if that was the case. Less than 1% transitioned to opioid use disorder medication. And this was in Vermont, the state that is considered one of the best based on this hub-and-spoke system about getting people treated. So if it's less than 1% in Vermont, how are we doing in the other states? Access to primary care. This study was quoted earlier this morning too, as well, from Michigan. 41% of 194 primary care clinics in Michigan declined to schedule an appointment for a new patient who was currently taking opioids for chronic pain. This isn't trivial. My father's not on opioids, but when he made a call to a new doctor, first question about insurance, the second is opioids. We don't prescribe them, so don't come here expecting. That's a filtering mechanism. Let me tell you that we cannot really make patients safe if there's no doctor who can assume their care. But we've set up incentives in which this feels like the natural thing for a practice to do. How should we interpret these adverse events? I mentioned Jay Lawrence before. Here's one which is really tricky. This is a comment on a public article, public comment. My son committed suicide 4 months after his doctor took him multiple pain meds. I'd really like to study this. I'm going to find out what happened. There's one individual, not a state institution, one person voluntarily found about 300 mentions like this on social media. 85 of my team has been able to link to an identifiable death. But should we make causal claims about the suicides? I don't think we can. We have to study those events like scientists. I think that we should adopt a patient safety framework. Just like a plane crash, there are multiple factors that merit study and attention. And we are required out there to track and analyze many safety events from falls to wrong side operations. So let's do it for this too. 10 million people involved. What happens to them should matter. For me, personally, seeing in action after safety problems were reported by me and others was an inflection point for my work. It was necessary once I realized that you could report a safety event not see an official response to protection of patients to speed up. And I did wind up with a somewhat different scientific view, one that may be at odds a little bit with what you hear today. And I might not be right. I'll just share it with you. Why might one be a tad skeptical of the focus of dose reduction as the primary path to patient safety? Let me say up front, I don't escalate doses much at all. I accept that there is some additional risk incurred every time a dose escalation is contemplated. But I wind up thinking that dose is relevant and somewhat overemphasized in understanding the risk of death. Here is Amy Bonner's paper from 2011. Higher dose associated with 7 times higher risk of death. Age, 18 to 29, 5 times higher risk of death than a 60 to 69-year-old. Whites, 3 times higher risk of death than blacks. We could apply this information as if every association found was causal. We could say, hey, my patient's dose is high, but it's an older black man, so I don't need to worry. We don't feel really comfortable with that. I think we have to accept the reality that there are factors as important as dose that are sometimes visible to us in clinic, but don't necessarily pop out in large retrospective database exercises. Life chaos, the return of a very difficult relationship. I have a patient whose pain gets out of control every time he gets back together with his ex-girlfriend. Return to alcohol use. There are a number of things of instability of various kinds that we can see and we can respond to and we can treat. But they don't all come out of big databases. Some of these things are not measured, but they are correlated with the dose that we prescribe, the race, and the age. The other reason I'm a little less focused on dose is that I think to save lives we have to go where the deaths are. And this is data from 2002 to 2009, published by Amy Bonner. The red line shows the range of doses that were prescribed to veterans who died of overdose. There is clearly an association in which that curve is to the right of the gray line, which is people who didn't die. There's some association there. But it still is the case that most of the red line, even in the heyday of reckless and irresponsible prescribing, was to the left of 90 milligrams. At my hospital today, less than 2% of chronic opioid recipients are at over 100. I've had to deal with the ones under 100. From 2010 to 2016, VA opioid prescriptions are down 52%. Dr. Bonner's team published a paper showing that overdoses have not changed as of 2016. So there's something else going on. Our theory of the problem cannot be just predicated around a number. And in fact, we have data to show us other things that do matter. This is a list of risk factors that have popped out of the literature, citations on the right, that are also associated with overdose risk. These things are things we can respond to. These are things we can try to do. Do I have proof that if you mitigate all these, reduce overdose risk? No. But it seems plausible. So I go back to a more fundamental question, which is who is the person we wish to help? And what is our model for care for a person with often multiple morbidities? All those things that I mentioned were at risk of overdose. I was kind of borrowing the model for how to think about people who've wound up in a maladaptive and unhealthy behavioral pattern in relation to their pain. I have modified this from work by Dr. A.J. Hopper, a close colleague and friend. All of these things, aging, medical illness, psychiatric illness, polypharmacy, social determinants, these things all play a role in setting up a phenotype of somebody who's doing rather poorly on their opioids or doing rather poorly without them. And the goal is to help them achieve behavioral changes that can help them set up a new adaptive framework. And taper may be very much part of that. Coordinated care may be very much part of that. Multiple disciplines may be part of it. My own practice is close to the end here. My approach is as follows. You can take it or leave it. I assess the full history, social history, trauma, the person's sense of self-advocacy, and the substances they use. I ask about function. What do you do? What holds you back? I craft a new pain understanding of the patient, including the brain's role, and help them try to set up new goals for themselves. I do introduce a new understanding of risk, very much in the way that Dr. Merrill talked about, and the medications that cause problems that we didn't recognize before, and I assess the manageability of the patient's behavior in relation to my team. I have time to do this because I'm paid to do it. Should be compensated for to do this. In terms of opioids, and the gentleman on the right actually consented for this. This is in the Stat News article. If they're stable, I discuss taper versus monitoring. I work on behavioral activation, exercise, sleep. If we are tapering, I say, we'll reverse course if we say harm. I haven't yet seen a study that suggests that all tapering must be unidirectional. If the patient's poorly functioning and they're really having difficulties in their life and with my team, we have options. I can intensify the monitoring and use the leverage of my prescription, that is a power play, to move them toward rehabilitative activity. Or I can switch to buprenorphine. I don't have a lot of evidence on that per se, but I've seen some patients do well with it. It seemed to be promising. And try to find choices the patient can make. I do see taper as sometimes helpful, but with risk of adverse outcome. I have required it, but rarely. My reasoning on tapers is as follows. Any doctor who thinks a patient is harmed has authority, as I see it, to change the treatment. And that includes tapering with or without the consent of the patient. Much as Dr. Krebs said, we are professionals, we have to make that decision. But each decision we make entails risk and potential benefit. So far, we lack prospective evidence that a patient is actually made safer by dose reduction. There's a history of our adoption of practices based on strong cases from observational data where those practices did not turn out to be well. Estrogen for all women after menopause, flecainide and lidocaine after myocardial infarction, hemoglobin A1C driving the sugar down to less than 7% for all patients. Every one of these had a rock-solid case. Every one of them was found to be harmful after randomized controls trials were done, at least on average. To me, the overdose event is a web of risks, not just a dose. And we can make that web worse with taper, particularly if it is carried out in a way that is threatening to the patient. And it's much more likely to be threatening to the patient if the clinician taking that action is acting on the basis of fear from multiple conflicting mandates from 10 to 20 different agencies speaking them to at once. That sets up for that interaction. We can also make it worse by if it's carried out non-expertly or without adequate resources to protect the patient. What I think will help is that any entity that urges pain care changes, whether it's this one or any other, must demand that we track patient-level outcomes, including life and death. Care, as I see it, is not for the opioid, but for a person with a life history. I consider both taper and intensified monitoring of high-risk patients as entirely viable. We must tangibly support protection of clinical relationships. This gets back to how we got into the mess where we have to have an FDA warning, a CDC clarification. I think we should offer mentoring and guidance for prescribers and provide both electronic advice and telephone advice to the doctors at our hospital. Safe harbor for prescribers so they're not acting based on fear. And access to mental and complementary health. And I would advocate a repudiation of metrics and tools that reward the abandonment of patients. Any situation where your performance improves by being able to say, we don't know, the patients don't come around here anymore, is not a metric we should be encouraging. With that, I'd like to close. I value your feedback. I'd like to learn how this talk was received. There's a QR code. Whether you've been a speaker here or an attendee, I'd like to know what you heard. That's only 6 questions. And then there's a couple articles, one with Dr. Adam Gordon, one with Dr. Jim Hopper, that you'd like to check them out. Thank you very much for your attention.